I think one of the more interesting trends in ADHD research right now is that the symptoms really tend to fluctuate over a lifetime now that we're looking at this in more of a long-term view. And so I think upwards of about 2/3 of children into adulthood will actually have very fluctuating symptoms throughout their lifetime where they might go into a partial remission of their symptoms and then the symptoms may recur. Interestingly, a lot of children will go into a bit of a partial remission with lower ADHD symptoms in sort of early adolescence, even as the workload gets a little harder and the expectations get a little more at that time. Um, there is a smaller subset of children who will have consistent ADHD symptoms at sort of a higher level throughout lifetime. And then there's an even smaller subset who occasionally do go into a kind of a full remission of their ADHD symptoms after fully meeting diagnostic criteria at some point in childhood. The optimal treatment for ADHD is still our stimulant medications. They really have the largest effect size for improving ADHD symptoms, and then also for improving kind of more global impairment that children can experience beyond just kind of general symptoms. So our two stimulant medication classes are our methylphenidates and our amphetamines. And they really have very good effectiveness for a lot of children. The downsides are a lot of children will experience some adverse side effects with them, appetite suppression still being a big one, with weight loss being associated with it, and a slight decrease in height velocity. Also, some kind of more vague system like side effect complaints like headaches or stomach aches or nausea, or some mood or irritability with some of them in some children. Um, Other medication classes that are also effective for ADHD, we now have some non-stimulant options. So our norepinephrine reuptake inhibitors, that would be atomoxetine and also the newer viloxazine. Those are also effective for ADHD symptoms, for reducing symptoms. They're not quite as effective as the stimulants, but are a good alternative for kids who either don't respond well to the stimulants or can't tolerate them due to side effects. This class does also have some suppressed appetite with it as well, so you have to watch that closely. The other medication class would be your alpha agonists. That would be guanfacine and clonidine. These are also effective for treating ADHD symptoms, again, a little less so than the stimulants. They don't have as much effect on appetite, so that can be a benefit for some kids. And there's some evidence that shows that potentially using the stimulants and a non-stimulant together may have a slight additive benefit. So medications that are kind of in the pipeline, there's the newly approved dexmethylphenidate, which is a dexmethylphenidate prodrug with a norepinephrine dopamine reuptake inhibitor. So this one is similar to our stimulant classes, but it's also a prodrug. It has a longer duration for some of our, common stimulants that we use. So it can last up to 13 hours. So for a lot of our kids where the medicine's just wearing off before they finish homework or after school activities as their days kind of get longer, especially as they get older, this can be a really nice benefit for some kids. It's still pretty expensive for a lot of kids and a little hard to get, but it is approved. In phase 3 trials right now, there's centanafidine, which is a norepinephrine dopamine serotonin reuptake inhibitor, an SNDRI. So this would be a kind of new class targeting some different areas. It's showing some effectiveness, certainly in trials, not quite as effective as our stimulants, but up there with our serotonin reuptake inhibitors in terms of effectiveness. And there's theoretically potentially a mood benefit to this one for some of our children who also experience mood disorders, which are often co-occur with ADHD. it hasn't been fully proven that there's a mood benefit, but there's still that theoretical benefit, and they're still looking into that in clinical trials. I would recommend that we remember that every child is an individual. And while we look at large studies and what's effective, um, individual kids can respond really differently to different treatments, to different medications. And then really thinking about that newer research showing that those symptoms can fluctuate over a lifetime. So it's really important that we check in with our patients frequently. I really try to see my patients at least every 3 months, and then more often when we're changing our management plans, because not only would their can their response to treatment differ, but even their symptom load can start to change over time. So I think it's really important that we check in frequently. Um, Also that, different families have, different considerations in terms of cost of medications, feelings about medications, other treatments as well. So thinking about some of our additional things that we treat ADHD with. So therapy, parent support, school supports, many of which do show some small benefits as well. And the research can be mixed, but could be something that a family can really benefit from and really jump onto, or could be a big time burden. So really thinking about those individual differences with families and patients, what their needs are, what they feel like may be helpful to try, and then frequently checking in.